All right, good afternoon, everybody. I'm Jenny Pennycuff. I'm here to lead this webinar for anesthesia and analgesia. Today's topic is perioperative care of the cancer patient. All right, this is me here. So I'm an associate professor at MD Anderson Cancer Center. We have three wonderful panelists today. Our first one is Dr. Seema Deshpande. She's an associate professor and interim vice chair of faculty development of cardiothoracic anesthesiology fellowship director at the University of Maryland School of Medicine in Baltimore. Her article is called Cancer-Related Coagulopathy and Perioperative Considerations. We have Dr. Daniel Steffens. He's a director of surgical outcomes and research at the Research Center and Surgical Outcomes, the Surgical Outcomes Research Center at the Royal Prince Alfred Hospital at the University of Sydney. His article is called An Updated Systemic Review and Meta-Analysis of Unimodal Prehabilitation with Exercise Intervention to Enhance Postoperative Outcomes in Cancer Surgery. And we have Dr. Juan Cata. He's associate professor, term tenure, and vice chair of clinical research at the University of Texas MD Anderson Cancer Center. And his article is called The Association Between Perioperative Red Blood Cell Transfusions and 1-Year Mortality After Major Cancer Surgery, an International Multicenter Observational Study. So just a reminder, a recording of this and other past ANA webinars will be available on the IARS YouTube channel and on the ANA website. Thank you all for joining. And there'll be a Q&A after, and just use the Q&A button on the Zoom taskbar to type in your question. And with that, we'll get started.
Hello, everyone. Thank you to Anesthesia Analgesia for the invitation to speak at this webinar on the topic of cancer-related coagulopathy and its perioperative considerations. I have no disclosures, and today I will be talking about the prevalence and types of coagulation derangements in cancer, discuss the pathophysiology, and review the perioperative implications of cancer-related coagulation changes and their management. This brings us to the important question: why should we care? In a very nice editorial, Drs. Gotomukala and Gan talked about cancer being the major emerging public health concern globally. By 2030, there's projected to be an increase by 50% in the global incidence of cancer, an increase in cancer-related mortality by 60%. This means that more patients with cancer will present for surgical treatment, and they are doing so already. More specifically, why should we care about coagulation? Cancer patients have increased risk of coagulation abnormalities, and these impact morbidity and surgical outcomes. Improving our understanding of coagulation pathophysiology in the cancer patient population and related management strategies will help us improve care of our patients. Overall, the biggest challenge for us as perioperative physicians is balancing the thrombotic and bleeding risks. Moving on to epidemiology. Cancer patients have an increased risk of venous thromboembolism at a rate of 7 to 11 times higher than the normal population, and the risk of a fatal PE is 3 times greater in all care settings. Arterial thromboemboli are also more frequent, and typically present as strokes or MIs, but can also occur in many atypical locations. Not to forget about bleeding, which can occur in 10% of patients with solid tumors and up to 30% in hematological cancers. The clinical presentation of coagulation derangements in cancer falls under 2 broad categories: thrombotic complications and hemorrhagic manifestations. Certain cancers are at a high risk for thromboembolic complications, while the others may present with predominantly hemorrhagic manifestations. Overall, thrombotic complications are more common than hemorrhagic complications in ambulatory care settings and are associated with high morbidity and mortality. I already mentioned the thrombotic complications of venous thromboembolism, PE, and arterial thromboembolism. Non-bacterial thrombotic endocarditis, thrombotic microangiopathy or TMA, and veno-occlusive disease are other thrombotic complications that are rare. Thrombotic microangiopathy and veno-occlusive disease have a very poor prognosis. TMA is a rare but often devastating condition which is seen in a variety of clinical situations other than cancer, such as solid organ transplants, and presents clinically as thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. In cancer patients, however, classic TMA is not seen, but a similar syndrome, and it is observed in specific clinical situations with certain chemotherapeutic agents, targeted therapies, and vascular endothelial growth factor inhibitor treatment, stem cell transplant, and occasionally due to the cancer itself in absence of chemo. And unfortunately, there is no clear evidence of benefit of treatment which is effective in other forms of TMA, such as plasmapheresis. So anesthesiologists need to be aware of this devastating complication. Thrombotic risk can approximately double in the perioperative period, depending upon cancer type, stage, surgical procedure, with the highest odds in advanced solid stage cancers, leukemias, lymphomas, general surgery requiring more than 2 hours of anesthesia or prolonged bed rest. And here you can see some of the other risk factors associated with cancer related thrombosis. Another mention of the types of cancers associated. The high risk ones are pancreatic cancer, lung cancer, gynecological cancers, stomach cancer. You can see renal, bladder, brain, and hematological cancers. Lower risk cancers such as breast, prostate, and colorectal cancer, however, have a very high prevalence, and hence you can see thrombotic manifestations in these cancers also. The highest risk is the first 6 months after the diagnosis of the cancer, with peak risk between 3 to 6 months. So, anesthesiologists must be able to identify the high risk patients to customize perioperative care and reduce complications. Moving on to hemorrhagic complications. Thrombocytopenia is a major cause for abnormal bleeding in patients with cancer. Chemotherapy is the most common cause of thrombocytopenia, 21 to 22%. Bone marrow infiltration due to the cancer, radiation-induced thrombocytopenia, DIC, acquired von Willebrand disease, and certain chemotherapy medications are other causes of bleeding in cancer. The pathophysiology of coagulation derangements in cancer is the result of complex interaction between the cancer cells, the coagulation system, and activation of multiple endogenous systems in the host. This figure illustrates the complex pathophysiology of cancer-associated thrombosis. Tumor cells release procoagulant factors, of which tissue factor is the most important one. They also release microparticles carrying tissue factor and inflammatory cytokines TNF alpha and interleukin 1 beta. The tissue factor forms a complex with activated factor 7 and ultimately leads to the generation of thrombin. Cytokines released also activate leukocytes, leading to the formation of neutrophil extracellular traps, activation of factor 12, and then again through the clotting cascade, ultimately to thrombin generation. Cytokines also activate the endothelium to promote further procoagulant reactions via expression of tissue factor and von Willebrand factor, which provides a surface for platelet adhesion and thrombin generation. In the meantime, endogenous antithrombotic protections are also reduced since exposure to cytokines leads to downregulation of thrombomodulin on the endothelial cell surface. Microvascular clot formation ensues, which impairs organ perfusion, and tumor-released angiogenic factors such as vascular endothelial growth factor promote angiogenesis while contributing to further tumor invasion. Moving on to perioperative considerations. What should we look at? There are more preoperative considerations than are listed on the slide, but focusing on the important ones, they can broadly be divided into cancer-related considerations, coagulation-related considerations, and patient factors. I already talked about cancer type and stage earlier. Other considerations that are really important are a thorough review of treatment history, particularly chemotherapy, a review of the anticoagulants or antiplatelets used, and the pertinent lab tests, and finally, other important factors such as the functional status of the patient, comorbidities, type of surgery, potential duration of anesthesia, and the plan for thromboprophylaxis. While reviewing treatment history, it is important to note the type of chemotherapy since it impacts coagulation significantly. For example, some of the commonly used therapies these days, such as the monoclonal antibodies and other medications such as paclitaxel and carboplatin, can cause both thrombosis and bleeding. In order to decide on thromboprophylaxis, it is important to be able to assess thrombotic risk. There are numerous risk assessment models, or RAMs, available to assess risk for thrombosis. There is the well-validated Khorana score and the newer RAMs, known as the Compass CAT RAM and the Vienna Cancer Thrombosis Study RAM. But in the surgical arena, the Caprini RAM is well known. Implementation of this RAM in lung and esophageal cancer surgeries reduced the risk of VTE by 4%. This is an overview of the Caprini RAM scoring criteria. Based on this criteria, low-risk patients with a score of 0 to 4 require no extended VT prophylaxis other than hospitalization, whereas patients with moderate risk, that is a score of 5 to 8, require 10 days postoperative thromboprophylaxis, and for patients with a high risk, that is a score of 9 or more, 30 days of extended prophylaxis is recommended. Low molecular weight heparin or unfractionated heparin is typically used for surgical thromboprophylaxis. It is started 2 to 12 hours before major abdominal or pelvic cancer surgeries in absence of contraindications, and the timing of unfractionated heparin is usually 1 to 2 hours, and low molecular weight heparin 4 to 6 hours prior to surgery. For low molecular weight heparin, the highest recommended dose is superior to lower doses in reducing DVT. And the biggest challenge is really balancing bleeding versus thrombotic risk when it comes to surgical thromboprophylaxis. Thromboprophylaxis with direct oral anticoagulants or DOACs before surgery should follow high thrombotic risk recommendations in surgical patients. Now, in cases of low or high surgical bleeding risk, DOACs should be discontinued 2 or 3 days before surgery if the renal function is normal, as you can see on this chart here, and 1 to 2 days are added to each category with impaired renal function. If anticipated surgical time is delayed beyond the 2 to 3 day window of DOAC discontinuation, bridging with low molecular weight heparin can be done. Moving on to important intraoperative considerations. I had alluded to the fact earlier that general anesthesia duration of greater than 2 hours can increase VT risk. Regional anesthesia should be considered when feasible based on the type of surgery and in accordance with ASRA guidelines. A large retrospective study showed a relative risk reduction of 41 to 52% for VTE events in general surgery patients receiving regional anesthesia versus general. Viscoelastic testing is also very useful for real-time coagulation monitoring. Viscoelastic testing in the form of TEG or ROTEM provides a global assessment of the clotting cascade as compared to at one point in time. They have been shown to provide good utility in guiding blood product administration, as well as in the diagnosis of thrombocytopenia and hypofibrinogenemia, which has ultimately led to reduction in transfusion requirements. Hypercoagulability is commonly seen, but the predictive value of that on viscoelastic testing is a little unclear due to lack of large prospective studies. Bleeding in cancer patients can be due to many causes, some of which I discussed earlier. Some of these causes are vascular injury, platelet dysfunction, and preoperative anticoagulation. Cancer patients on anticoagulants had a threefold increase in bleeding compared to non-cancer patients. Patients whose platelet count was less than 80,000 had fourfold higher odds of fatal bleeding compared with non-cancer patients. Higher risk surgery is another factor. Cancer patients with solid organ or hematological cancers undergoing cardiac surgery had more bleeding and higher transfusion rates. Transfusion of blood products have well-established risks, and this holds true for the surgical cancer patient as well. There is an increased risk of infection, recurrence of cancer, and lower survival in these immunocompromised patients. So we must make every effort to limit blood transfusions if possible in this vulnerable patient population. When there's significant bleeding, blood and blood component transfusions are, of course, necessary. A few caveats to blood component transfusion in cancer patients. Leukocyte-reduced platelet concentrates are recommended, particularly in solid or hematological cancers with stem cell transplants, to prevent the immune response to foreign contaminating leukocytes. Irradiated platelets are warranted, particularly in leukemia and lymphoma patients treated with specific chemotherapeutic agents, as you can see on the screen here. Due to lack of specific guidelines for perioperative bleeding management in cancer patients, recommendations are extrapolated from those for the general population. The 2015 ASA practice guidelines recommend use of desmopressin, antifibrinolytics, and factor concentrates. And antifibrinolytics have been shown to reduce blood loss in major oncological surgery without increasing the risk of complications. Since large trials in cancer patients are lacking regarding the use of PCC, dosing and safety data has been taken from other high-risk VTE populations. Trauma and cardiac surgery guidelines recommend low-dose PCC after correction of platelet and fibrinogen deficiencies when the clotting time on the rotum is greater than 100 seconds or R time on the TEG greater than 12 minutes. The 2022 European Society of Anesthesiology guidelines also recommend low-dose PCC. With major hemorrhage, rarely a DIC or DIC-like syndrome may develop in the surgical cancer patient with a high mortality and morbidity. Typically, this occurs with the severe depletion of platelets and fibrinogen, and the guidelines for DIC management follow the standard International Society of Thrombosis and Hemostasis guidelines. In the postoperative period, thromboembolic complications in the surgical cancer patient are the primary cause of 30-day mortality. Typically, low molecular weight heparin or unfractionated heparin is resumed 12 to 24 hours post-op unless there's a contraindication, and DOACs typically restarted at 48 to 72 hours, again, assuming hemostasis is achieved. Mechanical compressions are an alternative if there is significant bleeding. I already mentioned the use of the Caprini RAM earlier in my talk to guide postoperative thromboprophylaxis. And you can see that here on the slide, with the high-risk patient requiring 30 days of postoperative thromboprophylaxis. In conclusion, what I'd like you to take away from my talk is that cancer-related coagulopathy, both thrombosis and bleeding, contributes to significant perioperative morbidity and mortality. Coagulopathy in cancer is a result of a complex interaction between the tumor biology, host systems, and cancer treatments, and the perioperative period is a high-risk one. It is important for us to understand the mechanisms, risk factors, and use individualized strategies to improve surgical outcomes and survival for our cancer patients.
Hello everyone, my name is Daniel Steffens and today I'll be presenting the study titled On Updated Systematic Review and Meta-Analysis of Unimodal Prehabilitation with Exercise Interventions to Enhance Postoperative Outcomes in Cancer Surgery. I have no disclosures. Cancer is a quite burden condition. Each year we have around 20 million new cases being diagnosed and approximately 2 million deaths worldwide. There is a curative treatment for this condition, which includes major surgery. And we know that surgery provides some beneficial outcomes for patients in terms of survival that can range from 40 to 60%, according to this cancer type and the stage of the disease. The consequence of surgery is that some patients, around 30 to 7% of them, will develop postoperative complications during the postoperative period. And this is going to have some consequences on the patient recovery, and they can stay in hospital around for 7 to 21 days. Obviously, all that together will influence the actual cost of the treatment for these patients that can range from 60 to 150,000 per admission. During the treatment journey for these patients face quite a lot of challenges during the preoperative periods. They obviously are having the chance of being diagnosed with cancer. Some of these patients will come with some risk factors. Other patients will benefit from having neoadjuvant therapy. So all that put patients in risk of developing adverse events while they are in hospital. While they are in hospitals, there are stress, obviously, from the surgery. For GI cancer patients, for example, some of them will have a stoma formed, and they also have some in-hospital complications being developed as well. During the postoperative period is not different. Some patients will develop post-discharge complications. Other patients will benefit from having adjuvant therapy. And for the GI cancer patients, again, some of them will have their stoma reversed. So I guess what we're trying to establish is if it's delivering a prehabilitation for these patients actually supports their recovery. So this is sort of what we're seeing. Patients with high complication rates, staying in hospital for a long time, have a poorer quality of life and an increased cost. We want to see how we can actually reduce those complications, reduce the length of stay, improve their quality of life, and reduce the cost as well. So we started doing some background work on this to see if actually rehabilitation can help these patients. We've done quite a few background studies. So this one is the first one that we've done, which assessed preoperative physical activity in a subjective sort of level and look into the impact of that with postoperative outcomes. So what we found in this study is that patients that have a lower physical activity level in the preoperative, they were the ones associated with worse surgical outcomes. A similar path was identified when we look into a more objective measure of physical activity. For example, when we use a CPAT to assess these patients. We also noticed that patients that had a better function preoperatively, they actually have better outcomes in the postoperative. We look into sort of the impact of preoperative nutrition as well. So those patients that have better nutrition status in the preoperative were also associated with better outcomes in the postoperative, and not differently when we look into sort of psychological status. Patients that were better mentally in the preoperative period, they had better outcomes than those that were with some sort of serious mental illness. So obviously, there is a very strong message here saying that healthier patients have better outcomes after their surgery. So we decided to do a systematic review to look into the effect of perhaps delivering a pre-op exercise intervention for patients undergoing cancer surgery. This is our first review that was completed in 2018. In this review, we found a small number of trials that were in the literature at that time. Most of this review and the evidence of this review comes from lung cancer patients, where we identify 5 trials. And what we notice is that those patients, if they actually participated on a pre-op exercise program, they actually had 50% reduced chance of actually developing postoperative complications compared to a control group. Similarly, when we look at length of stay, patients on the pre-op exercise group, they actually stay in hospital almost 3 days less than in the control group. So there's a quite strong signal here, especially on the lung cancer cohort. What we notice is that for other sort of cancer types, there is little evidence and not many trials available at that time. With that in mind, we decided to look into a bit deeper into the trials, and one of the things that we sort of focused was the quality of those trials. And as you can see by this study that we performed, 75% of the trials that we look at, they had some high risk of bias in them. Also, when we look at the outcomes that people are reporting in those trials, we can see that there was a heterogeneity in those outcomes, and we identified a number of outcomes that were explored within individual trials, make it pretty hard for interpretation of those results. The other thing that we looked at was the power calculation of those trials. So what we sort of encountered was that pretty much half of the trials, we couldn't actually replicate their sample size calculation. So, you know, again, this makes a bit difficult for the primary outcome and the estimates of that and the power for that outcomes. And then finally, what we did recently, we looked at the actual fragility of those trials as well. And what we noticed was that the median fragility index for those trials is actually 1. So what that means is that we only need 1 patient to change from not having a complication to have a complication for that trial to change from significant to a non-significant result. So that means that those trials were quite fragile. The sort of other study to show how heterogeneous the evidence is this sort of review that we've done. And here you can see how many cancer types. So we identify 14 different sort of cancer types with the current literature that explore the effectiveness of rehabilitation on surgical outcomes. Within those trials, you can see that they applied 13 different interventions or a combination of interventions. And the duration as well of the delivery of that intervention varied from 2 weeks to up to 4 weeks. So there's quite a lot of heterogeneity within sort of the trials that we investigated. Well, the other thing that we did is I did a quick search on PubMed, and here you can see the rehabilitation evidence over the last 5 years or so. You can see that there was a big boom in the rehabilitation evidence. And with that in mind, we thought we would update our systematic review to see if we encountered any different sort of results. Therefore, the primary aim of this review is to determine the efficacy of rehabilitation with exercise interventions in reducing postoperative complication rates among patients with cancer requiring surgery. The secondary aim is to determine the efficacy of rehabilitation on length of hospital stay. So in terms of this study, we performed the search in 6 medical databases: Medline, Embase, Sinal, Cochrane, PsyInfo, and AMED. And we also performed citation tracking of the identified literature. Our search was conducted from inception to April 2023. We apply no language or publication restrictions for this search. So, in terms of the studies that we included in this review, we included randomized controlled trials or quasi-randomized controlled trials. In terms of the population of interest, were adult patients. They must be 18 or over, undergoing surgery for cancer within the pelvis or abdomen or chest. Cancer such as breast cancers were excluded. In terms of the intervention, we included trials that have intervention that was unimodal preoperative exercise intervention. So what that means is that included at least aerobic and/or resistance training and/or respiratory muscle training within their intervention. And also they compared that with a control group that had no intervention or minimal intervention as a standard of care. In terms of the outcomes that we sort of extracted data from, the primary outcome is complication rates, and the secondary outcome is the length of hospital stay. We assess the risk of bias of these trials using the Cochrane risk of bias tool, which has 7 domains. Within those 7 domains, we rate the outcomes into low, unclear, or high risk of bias. We also assess the quality of these trials using the grade approach. And again, the grade is rated high, moderate, low, or very low quality of evidence. All the pooled estimates are rated high to start with, and they are downgraded based on limitation of study design, inconsistency of results, and also imprecision. In terms of our analysis for our dichotomous outcomes, which was postoperative complication rates, we estimated the relative risk in the 95 confidence interval. For our continuous outcomes, which was length of hospital stay, we estimated the mean difference in the 95 confidence interval. We performed meta-analysis using random effect models. So in terms of our results, our current or our original search identified 4,000 records. Out of those 4,000 records, 32 trials met the eligibility and were included in this updated review. So a bit of the characteristics of the included studies or trials. We have 5 trials of genitourinary cancer, 9 trials on lower GI cancer, 6 trials on upper GI cancer, and 11 trials on lung cancer. So we can see that most of the trials were within lung cancer again. Preoperative exercise, in terms of the interventions delivered within 1 day to 14 weeks preoperatively. So there's a lot of variation in terms of the preoperative exercise sessions, and included either aerobic training, resistance training, or respiratory muscle training. When we look at the risk of bias of the current trials that we identified, most of these trials present some risk of bias. We'll look at the primary outcome of our review. So we divided this within the cancer stream. So genitourinary cancers, we found no difference in the primary outcome between prehab and control. The same was observed for lower GI cancer, so no difference in complication rates between prehab and control. And the same was identified for upper GI. Again, no difference between prehab and control for all those sort of complications that we extracted. Although for lung cancer, what we identified was that for major complication, atelectasis, pulmonary complication, respiratory tract complications, all that prehabilitation was actually effective in reducing on approximately 50% the complication rates when we compare to control group. Length of stay, we show some similar results where no difference observed within all cancer types except for lung cancer that show a reduction to 2.5 days within the identified trials. So to sum up our results, Prehabilitation with preoperative exercise significantly reduces postoperative complication rates and length of hospital stay in patients undergoing lung cancer surgery, but does not demonstrate effectiveness in other cancer populations. While prehabilitation with exercise is effective for patients undergoing lung cancer surgery, further research is needed to establish its effectiveness in other cancer populations undergoing surgery. Thank you.
And I am the principal investigator of the ARC study. It's a pleasure for me to be presenting in this webinar the results of the study, and thank you to the IARS and Dr. Pennycuff for inviting me to present this work. This presentation is related to the, as I said, the ARCA-1 study, in which we study the association between perioperative RBC transfusions and 1-year mortality after major cancer surgery. I have no conflict of interest to declare related to this work. As a background, patients undergoing cancer surgery commonly receive blood transfusions, mostly if these procedures are considered major oncological surgeries, and it's been reported that up to 85% of the patients may receive blood transfusions, mostly when they go procedures such as IVC thrombectomies or large spine tumor resections. Typically, patients are transfused because anemia or blood loss, this latter more commonly intraoperatively. Evidence suggests that there is a possible link between RBC transfusions and worse oncological and non-oncological outcomes in the postoperative period. Data indicates that blood transfusions are associated with what is called TRIM, or transfusion-related immune modulation. These occur because at the time of storage, red blood cells undergo significant physical and biochemical or biological changes. Lysis of older RBCs produce iron overload, inflammation, complement activation, and features of immune suppression, as you can see in this graphic. So the motivation of our study was to overcome some of the limitations of previous investigations and understand the pattern of blood transfusions in major oncological surgery worldwide. A further motivation is that practice transfusions may have changed or are changing worldwide because there is no clear guidance on when and how to transfuse patients undergoing major oncological surgeries. So our objective was to evaluate whether perioperative RBC transfusions were associated with 1-year mortality and other adverse outcomes after major non-cardiac surgery. Our endpoints was 1-year all-cause mortality as a primary endpoint. As a secondary endpoint, we have 30-day morbidity mortality, cancer-specific mortality, and overall survival. We picked these outcomes because of the clinical relevance of them and because they have been previously studied and reported to be negatively influenced by blood transfusions. So, as I said, this was an international multi-center prospective observational study that occurred in most continents. Our patient population were adults undergoing major cancer surgery with curative intent, in which the risk of blood transfusion was low, as determined at the screening time. To account for confounders and some of the bias indications, we conducted a propensity score matching and a multivariate regression analysis. Our exposure, as I mentioned, was red blood cell transfusions that may have occurred 24 hours before surgery, during surgery, or 48 hours after surgery. As you can see, a little bit over 6,000 procedures were screened for eligibility. A little over 5,000 procedures did not meet inclusion criteria or had at least one exclusion criteria. Hence, we end up with a population of a little bit over 1,000 patients. I have to make the comment that our original sample size analysis was around 2,500 patients. Hence, we were underpowered at the time that we had to stop the study to detect our primary outcome. It's important to notice that we stopped the study at the middle of the COVID pandemic, where potentially blood transfusion strategies would have changed. At the time, we did not know. So we decided to stop the study because of that and because of extremely low recruitment. Some of the key characteristics of the patients included in the study is that only 5.7% received any preoperative anemia management before coming to the operating room. The median pre-transfusion hemoglobin, either pre, intra, or post-operatively, was 8.5. So these patients were anemic. The transfusion rate was 21%. And of course, patients who were transfused as expected had more anemia, had a higher ASA physical status, had coronary artery disease, and had received prior transfusions. Now, those patients also had longer surgery, higher blood loss, and underwent more often open procedures. Now, the median number of RBC transfused were 2. In terms of our primary and secondary endpoints, before matching, a significantly higher number of patients who were transfused died. The rate of 1-year mortality was almost 20% in those who were transfused versus 6.5 in the non-transfused group. After matching, the 1-year mortality rate remained higher but not statistically significant in those who were transfused, probably due to our lack of statistical power. However, the odds ratio for mortality was significantly higher in those who received blood transfusion. Now, when we investigated cancer-related mortality, The odds remained high, however, it was not statistically significant. But overall survival also was negatively impacted by blood transfusions, and this was statistically significant, as it was 30-day mortality rates, where those who were transfused had a mortality rate at 30 days postoperatively of 3.5% versus 0.7% in those who were not transfused. And this effect on mortality appeared to be dose dependent, with higher mortality in those who received more than 2 units of red blood cells. We also observed that postoperative complications were more common in those who received RBCs. Specifically, I'm mentioning those who were statistically significant, and you can see in the manuscript in the tables the list of complications. And those who were, as I said, statistically significant were bleeding, sepsis, acute kidney injury, pneumonia, ICU admission, and length of stay in the hospital. And most of these have been shown in previous randomized controlled trials investigating the effect of blood transfusions or retrospective studies. So, to conclude, nearly 1 every 5 cancer patients undergoing major oncological surgery receive a blood transfusion worldwide. Perioperative blood transfusion independently predict worse 1 year and cancer-related survival. However, I have to make a comment that although it was not statistically significant after propensity stop-call matching, we did not meet our initial sample size estimate. Also, it's important to highlight that low implementation of preoperative anemia optimization. As I said, around 5% of the patients have some anemia management prior to surgery, and this is an opportunity to implement anemia clinics, as many countries and centers are doing worldwide, but it still remains low. And with that, I'd like to thank IRS again and Dr. Pennycuff for the opportunity to present our work. I will be more than happy to answer any questions.
Thank you all so much for those great articles and presentations. We're going to open it up for Q&A. Feel free to write in the chat, and we can ask our panelists some questions. And while we are waiting for some questions to appear in the chat, I have a few already prepared. Let me get my notes here in order. So this is a question for Dr. Cata as well as Dr. Deshpande. As you both have already shown in your studies, that giving blood, even though it's a common practice in the ORs, can be detrimental to cancer patients with increased infections, decreased survival, and other poor outcomes. So my question to you is, the ASA has certain guidelines about giving blood products like PCC and whatnot. Do you think that the ASA should also make further guidelines or recommendations for transfusing blood in cancer patients to help guide clinicians?
Do you want to answer, or you want me to answer, Dr.?
Oh, go ahead, Dr. Cata. I can chime in later. Sure, please.
Okay. This is a great question. I don't think that the American Society of Anesthesia or any international society should change the guidelines here, because we don't have randomized control or large randomized control trials specifically addressing this. While all these associations are important, typically we transfuse patients who are requiring larger surgeries, and the risk of survival is per se compromised. So I think that if we follow what, at least here in the United States, the American Society recommends from 8 to 10, depending on comorbidities, I think we should stick to that. And that's what I think that we should be doing before making radical changes in blood transfusion triggers. And then the other thing is we don't know what are the blood transfusion triggers. Hemoglobin is perhaps a very poor transfusion trigger. But in the ORs, we don't have, as of now, in most countries, anything better than that.
Yeah, I think I would also like to chime in that I think I agree with Dr. Cata, but it's sort of more of a really individualized approach based on every patient. With a range of 7 to 10, you really just have to decide based upon your patient's comorbidities and things like that. It was interesting when I looked into the background for PCC usage, like I said in my talk earlier, we really don't have robust data in cancer patients. There has been some evidence to suggest that in major oncological surgery, the thrombotic complications and all that were not that high with, not higher, I should say, with the use of concentrates and things like that. But I think that, again, individualizing it, being a little bit cautious, but that is sort of why they talk about lower guidelines. And again, the caveat with the use of prothrombin, PCC, is the fact that, again, you have to replete the platelet part of it and the fibrinogen part of it. So I think that, again, there's a lot of variation in practice depending upon also what is available in your institution. So yes, I agree that, it's not a question so much of changing the guidelines as much as really just being individualizing everything to that particular patient and things like that.
Thank you both for your answers. I think, as you said, just having individual patient care would really help with the outcomes. I have a question for Dr. Steffens. For low resource settings with minimal axillary support, for example, low amounts of physiotherapists, how do you advise patients to increase cardiorespiratory exercise at home during the prehab period of 1 to 6 weeks, assuming that they are not very active or deconditioned from neoadjuvant therapy?
Okay, thank you. Thank you so much for the question, and thank you for the opportunity speaking here today as well. I mean, this is a question we normally get from a lot of centers. We recently conducted actually an international survey that involved 600 hospitals around the world. From that survey, we identified that around 20 to 40% of the centers, they do have some sort of resources to provide to patients, including physiotherapy and sort of other disciplines as well. But yes, I agree that this is a quite expensive sort of resource for the hospitals to have, especially when you consider the evidence that we have. And it depends how you look into it. Some people might say it's sort of a bit weak. Some people might say there's some moderate evidence in some aspects. I guess in terms of prehabilitation, there's something called universal prehabilitation. And what that is it's sort of written sort of information for patients. And we do have quite few centers that actually develop some quite nice sort of written information to patients. And there is a center in the UK, they call the Macmillan group, and they actually been doing some guidelines on it, and they have some very nice patient-facing sort of documentation that you can provide to patients. And in there, you're going to see that obviously there's not only physiotherapy, but other sort of disciplines advice as well. And I guess my advice is to start something simple first to get the patients engaged, such as daily walking, and ask them to sort of try to gradually increase, the speed of their walking and their pace. And in a way that they can actually talk, but they're not able to sort of sing at the time of sort of they're walking. So it's quite a brisk sort of walk. Ideally, they would getting towards before the surgery be able to engage in moderate sort of intensity activities, and they can start changing that, to simple sort of things like sit to stand and walking in the spot, and using weights that they can find at home, and also incorporating some breathing exercises as well, which is actually quite important to these patients. Obviously, all that will be different depending on the cancer sort of type that those patients will have. I guess the other sort of point I would make as well is there's a lot of technology coming into the market now. There's quite a lot of apps available for patients that there's some that are free, or they have like a 30-day sort of free period that they can use, which is quite resourceful. So also that is quite low cost. The other point to be made as well is making sure those patients, especially I think you mentioned that the patient wasn't into exercise. Those patients that are not into exercise and they are starting for the first time, it's good to sort of provide some sort of build the confidence and provide some reassurance for those patients. And one way of doing this is asking them to write, how many steps they do in the day, or the exertion as well of the exercise, the simple skills that you can sort of use for them to sort of do that, and then obviously build their confidence and endurance safely, at home without much resources. I hope that I was able to sort of answer that question in a very short time.
Great. And we have a follow-up for Dr. Steffens as well. The recent study published in the New England Journal of Medicine by the author is Cornea. There was a benefit to structured prehab versus standard prehab. So can the message to the patients be you should do more than you did previously?
Yeah, no, definitely. I guess I think I think I know what paper you're talking about. It was published this year, I think, and there's some paper from Australia as well, part of that paper. And what the paper is saying is that engagement on exercise with cognitive behavior sort of therapy actually resulted in sort of better survival for sort of those patients, and increase of sort of functional capacity as well. I guess, yes, that's the message that we sort of need to pass to patients, and encourage them engage into exercise. I think currently that there's another sort of review published on the BMJ, and this is from a group of Canadians and few others involved, led by Daniel McKinsack. And that paper included 200 trials on prehabilitation. And there is quite sort of a strong message in there that sort of, exercise preoperatively actually help patients in sort of reducing complications and so. And I think the message here from that paper is also that out of those 200 sort of trials, or 160 or so that they included, none of those saying that actually exercise was harmful to patients. So I think that's probably the message that we need to pass to people. I think perhaps we're not going to see miracles coming out of it in a very short term, but it's not going to cause any harm to them. And perhaps, this is a way of them starting engaging exercise, and then obviously continuing in the post-operative side of things, and make those patients engage and have a better sort of lifestyle, more healthier lifestyle in the post-operative recovery period. Yeah.
And I think we have time for one more question. This is for Dr. Deshpande. My question is to you is I don't know if you saw anything in your studies and your research for your article, but it showed that there was a higher risk of coagulopathic problems in African Americans and Asian or Pacific Islanders. Do you have any thoughts or assumptions of why this was observed, or did you see anything in your research to figure out why that was happening?
I don't remember off the top of my head. It is higher in women and African Americans, and lower in Asian Pacific Islanders, actually. But no, off the top of my head, I actually don't recall the basis behind that.
Thank you so much. We are approaching 4 o'clock. I don't think we have any other questions in our chat box here. I would like to thank all of our panelists for participating and the IRS for hosting this webinar. It was a really great time learning more about these topics and just having ways to improve my patient care.
Thank you very much.
Thank you.
Mhm.